the JAMA Network.
I'm Justin Beckelman. I'm an associate professor at the University of Pennsylvania Perelman School of Medicine, and I'm a practicing radiation oncologist at Penn's Abramson Cancer Center. We've known that end-of-life care is expensive, intensive, and not consistent with the wishes of our patients. We also know that still too many patients are dying in the hospital. But what we don't know is how the U.S. compares with other countries. The objective of the study was to conduct a systematic examination of place of death, either in the hospital or not, healthcare utilization, and hospital expenditures near the end of life for patients dying with cancer in 7 nations: Belgium, Canada, Germany, England, the Netherlands, Norway, and the United States. We designed the study as a retrospective cohort study that looked at patients dying with cancer in the year 2010 in these 7 countries. The main cohorts included patients over the age of 65, and then we looked at secondary analyses for patients of any age, patients with lung cancer over the age of 65, which was a more homogeneous cohort, and then for patients diagnosed in the year 2012. We had 3 main results. First, the United States and Netherlands have the lowest proportion of patients dying in the hospital. In the United States, only about 20% of patients near the end of life actually die in acute care hospitals. In the Netherlands, it was about 30%. Some nations like Belgium and Canada had nearly 50% of patients die in the hospital. We also found that the United States was actually not the most expensive health system. Rather, the United States was on par with Canada and Norway in terms of hospital expenditures over the 2 periods that we studied: 6 months before the end of life and 1 month before the end of life. In the United States, 40% of patients near the end of life were admitted to ICUs, and contrast that with less than 18% in other nations. In addition, the United States had the highest utilization of chemotherapy near the end of life in both periods. This study was the first study to do a cross-national comparison of end-of-life practices in the United States versus other nations. It was really a proof of concept that high-quality, comparable data can be produced to educate us all on these practices and where the opportunities are to improve. The essential takeaway here is that there's great variability across all the nations in end-of-life practices. There are 2 sets of next steps. So the first is clinical. We know we can do better in certain areas. We know we can reduce the intensity of care at the end of life in the United States. In other nations, we know we need to start to move end-of-life care out of hospitals. From a research perspective, I'd say that the main next step here is to think about extending our work not just to the hospital, but outside the hospital. So our work was limited to patients with cancer, was limited to patients who were admitted to the hospital. The next step is to look at outpatient visits, to look at end-of-life care as delivered at the home, as delivered in hospices, as delivered in locations outside of the hospital, and also to extend this beyond cancer, to extend this to other prevalent diseases where end-of-life care is also such a crucial concern.